Hi, today we will be discussing interprofessional quality improvement, making it real. I'm Beth Quatr.
And I'm Beth Turrentine from the University of Virginia. We would like to thank the Josiah Macy Foundation and the University of Virginia Center for Interprofessional Collaborations for their funding support of this project.
The goals of our project were to improve compliance with venous thromboembolism risk stratification in perioperative patients. Additionally, we wanted to identify perceived areas of improvement in the clinical learning environment.
A little bit of background on the project. Our institutional data showed that we had higher VTE event rates compared to national benchmark data. And to address this, we built a risk stratification tool linked to risk-based VTE prophylaxis medications and the electronic health record. However, it lacked a hard stop for completion due to system limitations, so it could be bypassed and not completed. Failure of risk stratification was defined as an adult patient, 18 years of age or older, not receiving VTE risk stratification within 24 hours of admission to the hospital.
We implemented a pilot curriculum using interprofessional teamwork and quality improvement training within an inpatient surgical setting. One surgery resident and 3 acute care nurse practitioner students voluntarily participated to become team leaders in the clinical quality initiatives. This was intentional. We wanted to start with a small team. We used a time variable, competency-based interprofessional education curriculum. The curriculum included lectures, clinical data, educational videos, simulation sessions, and fieldwork. All of this culminated in a quality project focused on improving VTE risk stratification compliance.
To begin this process, we gathered our team, the resident, the students, a quality improvement coach, School of Nursing and School of Medicine faculty, QI VTE coalition lead. At our institution, we have coalitions to address priority quality topics such as mortality, hospital-acquired pressure ulcer, and VTE. Each coalition has content experts, data analysts, and quality improvement coaches. We also included clinical team members and our EHR programmer. We felt strongly that the project be data-driven, an institutional priority, and embedded in the current institutional quality structure.
We began by establishing a baseline. We wanted to understand the needs of our participants. We asked them to complete a quality assessment and improvement self-assessment. We also had them complete the quality improvement knowledge application tool. Both of these gave us tremendous insight and helped to guide us as we individualized our training program. For example, through the quality assessment and improvement self-assessment, we identified that our learners needed more opportunities to use small cycles of change. They needed to learn how to implement a structured plan and test it. They also needed to understand how to use the PDSA model. Through the quality improvement knowledge application tool, we identified an opportunity to enhance their use of the AIM statement. All of this was time variable and very much guided by the learners.
Team training began with participants completing the team skills scale as a baseline measure. They completed it again at the end of the study. The team skills scale is a 17-item, 5-point Likert scale from poor to excellent. It's a self-assessment that measures one's perceived ability to carry out tasks, from treating team members as colleagues, to strengthening cooperation among disciplines, to helping draw out team members who are not participating actively in meetings. Team training continued with an interprofessional quality improvement VTE case review simulation. We had standardized multidisciplinary team members, including a surgeon, nurses, pharmacist, physical therapist, and social worker. The participants took the lead in reviewing a surgical patient who had experienced a PE. They had to contend with team members who were reticent to join the conversation or who were belligerent in responding. And these were areas identified as needing improvement from the team skills scale. Participants attended a pre-brief session that included tips for leading and managing meetings. At the conclusion of the simulation, participants were offered the opportunity to repeat the simulation in a different role. And then a post-simulation debrief was held that included an interactive discussion, reflection, and critique. And we used the plus delta technique. We began with highlighting the positives and then suggested changes. For instance, stakeholders were encouraged to participate by calling on them. But a suggestion was to use Post-it notes to have those available for team members to write suggestions on. Maybe a good alternative to encourage people who are reticent to join the conversation or to limit those who are more verbose. The simulation session was recorded and participants were scored using the Interprofessional Professionalism Assessment. This tool is used to evaluate an entry-level health professional's demonstration of professionalism when interacting with members of other professions. The 5 items addressing communication were scored on a 5-point Likert scale, from strongly disagree to strongly agree.
After taking a deep dive into the VTE data, the learners also met with stakeholders. These stakeholders included quality improvement leads, but also included frontline clinicians. Both the information from the frontline clinicians and the observations of current VTE risk stratification processes led them to develop the How to Navigate the VTE screening tool. This guide included screenshots and explanatory text. Unfortunately, with the COVID-19 pandemic, in-person meetings were eliminated. The learners needed to shift to an online education plan and roles were reassigned. This limited the participants' ability to evaluate the final quality project. However, they were able to disseminate this information electronically.
At the close of the project, a researcher not involved in the educational sessions interviewed participants using an adapted clinical learning environment checklist, which included 12 open-ended questions addressing leadership, things like clinicians in the health system embrace IPE, and collaborative care with the resident and the students during participation in the QI project, to site readiness, which included team-based learning and communication was encouraged, to process. I'm prepared to independently lead the next quality improvement project.
What were our lessons learned? The participants really valued the simulation. Our original plan had been to include the simulation early in the training program. However, due to logistics, we were required to incorporate it later into the program. However, we believe this ended up being a benefit because the learners were able during that time frame to connect and collaborate and build relationships that helped to enhance the simulation. Some individuals said that the program exceeded their expectations because more didactic was included than they anticipated. We also believe this was likely because we really tailored the didactic to their immediate needs. Again, that pre-assessment information guided our work and helped us to create a very individualized training program. The learners appreciated the opportunity to interact interprofessionally. The nurses commented that the physicians had scientific knowledge to bring to the table, and the physicians respected the nurses' ability to manage multiple patients under dynamic circumstances. Both said that they very much enjoyed meeting and working collaboratively with new colleagues. Some felt connected to the larger institution through this process. They really began to appreciate the role of the VTE Coalition and their engagement with the Institutional VTE Coalition. However, others did not feel the same. They did not feel that level of connection and were unsure if their work was valued beyond their team. This may have been to the COVID-19 pandemic and the fact that the project was abruptly brought to an end and they did not have the opportunity to see the intervention through and to see the evaluation through. Similarly, some suggested a longer timeline to implement and evaluate the change project. Again, with different circumstances, the COVID-19 pandemic not having been at the forefront, perhaps this would have been a different learning environment.
In conclusion, while participating in an individually tailored and time variable interprofessional quality improvement training program, the participants learned and immediately applied new knowledge and skills. Through observational assessments and frontline team discussions, participants gathered data about the realities of clinical practice and processes. Through IPQI simulation activities, the learners were able to address self-identified opportunities for improvement and practice the nuances of team leadership during a root cause analysis.
The learners collaboratively identified a gap in perioperative VTE prevention clinical processes, and they developed a streamlined strategy to improve the VTE risk stratification process. Both quantitative and qualitative assessments were performed to evaluate the training program and the interprofessional QI project. This project provided insights into optimizing the clinical learning environment and contributed to enhancements in interprofessional practice of risk stratifying perioperative patients to reduce VTE events. Thank you.
Our lightning talk will be held on August 6th from 1:15 to 2:15 if you'd like to join us for further discussion of our project.
Again, we'd like to thank the Josiah Macy Foundation and the University of Virginia's Center for Interprofessional Collaborations for their funding and support of this project.